Thank you. Nang binaga na ni Lola. Na daro guli no nang nalamanang pitigil. Na gamma maringai daro lenga. Welcome, my name is Annie Lola. I'm a Darrell elder, and I acknowledge we are gathered on the land of Bidjigal. And I introduce myself in our Darrell language. Our Darrell language is now being brought back into our community through our Gujaga Foundation. Our language was lost when our people were put on an Aboriginal reserve, and our elders were only allowed to speak English, so it wasn't taught to the children and the grandchildren. But my grandchildren are now learning our language in our schools as Gujaga Foundation has introducing it to our schools, our preschools, and our daycare centres. And hopefully, if my brain can take it, I want to learn it too, so that one day maybe I can speak with my grandchildren in our own language. Bit of a dream of mine when I retire, so let's hope that I don't get dementia before then. I would like to pay my respects to elders past, present, and emerging, and extend that respect to all of you present here today. It's a pleasure to welcome you all to UNSW for Digital Health Week, Inclusive by Design 2024. Our welcome to country was traditionally done through performance of dance, song, and music to welcome other tribes to the land, as there are hundreds of different language groups in Aboriginal Australia, and communication was better done through music and song and dance. Today we welcome you in a contemporary way and ask that you respect the land, the culture, and traditions. We always like to thank our ancestors for taking care of our land, our oceans, and our waterways, as they only took what they needed to survive. That way, no families went hungry. Our people walked the land from Sydney Harbour to the Shoalhaven region. For people that don't know how far that is, it's up to 3 hours by car. And they did that seasonally so that to sustain the vegetation and the wildlife. That is how we have survived over 65,000 years and live in such a beautiful country. Sharing our traditional cultural knowledge and stories with the wider community enhances that Australia has a very strong Aboriginal culture. Our culture being passed down to our youth is very important to us, as one day they will be the keepers of the language, the culture, and our strong Aboriginal language and the future, so that, our culture is not lost. So on behalf of my ancestors and my community, I wish you all a very warm welcome. We are spiritual people. We believe our ancestors walk with us. May their spirits be with you, keep you all safe, wherever you may travel to or from. Budjeri Nandawabi. That means thank you and have a great day. Thank you.
Thank you, Auntie Lola, for that very nice welcome to country. So quickly, before I introduce the speakers, today's keynote runs from 1 p.m. to 2 p.m. and is also being live streamed. We will conclude the keynote with a panel of the two speakers and a question and answer session. And so we welcome questions both from the room and online. The theme for Digital Health Week 2024 is Inclusive by Design. And we've explored topics ranging from the advancements in accessible technology to tackling healthcare disparities and fostering diversity in healthcare leadership. The focus of this week has been on showcasing the significance of creating solutions that meet the diverse needs of individuals. We're very fortunate today that our keynote session at UNSW features two exceptional speakers. providing invaluable insights aligned with these critical topics. So let me first introduce our first speaker, Professor Michael Kidd. Michael is the inaugural director of the Centre for Future Health Systems at the University of New South Wales. He's had over 30 years of research experience in digital health innovation, focusing on electronic patient records, e-prescribing, digital communication, artificial intelligence, and telehealth. Importantly, Professor Kidd served as the Deputy Chief Medical Officer of Australia during the COVID-19 pandemic, overseeing the nation's primary care response for COVID-19. Professor Kidd is also the Foundation Director for the World Health Organization Collaborating Center on Family Medicine and Primary Care. Michael will be presenting today on digital inclusion lessons arising from the COVID-19 pandemic. So Michael, please.
Thank you, Ian, and good afternoon to everybody here at UNSW, and hello to everybody joining us from the University of Sydney, from the Hunter Medical Research Institute, and from other sites around the country. Thank you very much to Auntie Lola for that introduction that welcome to country, and we're very privileged at UNSW to be in a beautiful part of Australia. I'm going to talk about what we learned during the COVID-19 pandemic about digital inclusion, and talk about some of the innovations which occurred as a consequence of the pandemic. Now, it may seem odd to think that there was a silver lining to the COVID-19 pandemic and the incredible disruption which occurred in all of our lives, and the very high level of loss that so many people experienced during the pandemic, both here and in other parts of the world. But we have seen some major transformations in the use of digital technology as a consequence of the COVID-19 pandemic. And I think there's some really important lessons that we must make sure we don't lose. It includes that sometimes transformation can take place very quickly when we didn't expect that would actually happen. So let me tell you a story. In February of 2020, I was summoned back to Australia. I was working in Canada, and the then Chief Medical Officer of Australia, Brendan Murphy, contacted me and said, "Michael, if you're coming back to Australia, now is the time to come back, and have I got a job for you?" So I arrived in Canberra, and the Prime Minister had just released our national response plan for COVID-19, and Brendan said the Minister wants a primary care response plan to COVID-19, and I said, "Yep, that's fine. What do you already have in the national plan?" Well, the answer was nothing. And what do you already have prepared from past pandemics? And the answer was very little. So, and when do you need this plan? By lunchtime tomorrow. So I sat down with some wonderful colleagues in the Australian Government Department of Health, and we drafted out a plan for how to respond to COVID-19. And we did it based on these 5 principles. And I hope that you can see that there is a strong element of inclusion in these principles. Firstly, we needed to protect the people who are most vulnerable and most at risk of COVID-19. We knew from the experience of what had happened in the initial outbreaks in China, and then the outbreaks in places like South Korea, Iran, particularly in northern Italy, that elderly people were most at risk, and people with chronic disease, and people who are immunosuppressed of any age. We wanted to make sure that we had treatment services available to people presenting with symptoms of COVID-19, and that we were able to separate people who may be infected from people who weren't, to try and protect those presenting to healthcare systems for other reasons from being infected with COVID-19, while making sure those who were infected were diagnosed and given appropriate treatment. We wanted to make sure that regular healthcare could continue. One of the things we knew from past epidemics and pandemics is often people stay away from health services during a pandemic, and this puts at risk those with new medical problems, those with chronic diseases, and a lot of people who would be having immunisations and preventive health measures don't get those happening. And sometimes in epidemics and pandemics, more people end up dying from not engaging with the healthcare system for other reasons than end up dying from the infectious agent. Fourthly, we wanted to make sure that people working in primary care, in community-based healthcare settings, receive the same level of protection as people working in hospitals. This may seem very obvious to you, but the experience from past pandemics and epidemics is that often the protection is given to people working in hospitals and the people working in the community are left to their own devices. And this, of course, is not equitable. And of course, in a pandemic, someone with symptoms can present to anywhere in the healthcare system, not just to emergency rooms. Finally, we wanted to make sure that mental health services were boosted during the pandemic. Again, we knew from past experience that often there would be a very long tail of mental distress and illness extending beyond the end of the pandemic. And indeed, we're seeing that, aren't we, here in Australia with particularly young people who have been affected and their lives disrupted during the pandemic. So they were our principles. I just want to share with you some of the digital innovations that we brought into place. So firstly, to protect vulnerable people, we recognised that Australia was very soon going to go into lockdown, as was happening in the rest of the world. As soon as COVID-19 hit our shores, and this happened in February and in March of 2020, the country would start going into lockdown. And we needed to make sure that we were protecting vulnerable people and that people were able to get access to healthcare services even if they couldn't leave their own homes. And this meant we needed to introduce telehealth to the whole population. And this would allow people to be in their own homes and also healthcare workers to be working in isolation as well, to still be able to have healthcare services continue. Originally, we introduced telehealth just for the people who were most at risk of COVID-19, elderly people, people with chronic disease, people who are immunosuppressed. Within 2 days, we then introduced the ability to use telehealth by healthcare workers who were older people, had chronic disease or were immunosuppressed. And within 10 days of introducing telehealth, we rolled out telehealth to the entire population. And indeed, I expect most of you have probably had at least one telehealth consultation over the last few years with your chosen healthcare provider. Now, telehealth is nothing new in Australia. This is a photograph from 1926 showing a remote family consulting with the Royal Flying Doctor Service using a pedal radio. You can see, I'm not sure if it's mum or grandma there pedalling away, getting the radio to work. So we've had telehealth in different forms for a long time, but not for the whole population. We introduced telehealth by telephone and by video. We initially had Medicare benefits schedule access for vulnerable populations, then in 10 days expanded to everybody. We had a strong focus on mental health. We made it mandatory that if people needed in-person assessment, that would still be able to happen because we didn't want people just setting up just to do telehealth without the ability for people to get seen in person if that was needed for their presenting complaints. And the rationale behind introducing telehealth was we were worried about collapse of our health system, as we'd seen in Italy and elsewhere in those first weeks of COVID-19. And we were worried about people not getting their regular care and missing prevention. We introduced both telephone and video because of a very important element of digital inclusion, because we recognised that not everybody would have access to a smartphone, and not everybody, especially in the vulnerable populations, would be able to use a smartphone. And fortunately, we had evidence to show that video consultations are often not successful, particularly with older people with cognitive challenges. Minister Greg Hunt likes to describe that we implemented a decade's worth of work in 10 days. So 10 years we were planning to roll out telehealth to the whole of the population over 10 years as part of Australia's 10-year primary care strategy. we rolled it out in 10 days. People at Services Australia who set up the Medicare item numbers, and there were 350 new item numbers needed for telehealth items, said it was impossible, this would take 6 months. And the minister said, that's fine, you've got 10 days and we need this rolled out. And that's exactly what happened. And we've documented that. In fact, in my role as Deputy Chief Medical Officer, we documented a lot of the aspects of what happened during COVID-19 and published in the medical literature. So those lessons are there in perpetuity and are able to be accessed by people in the future if they want to know what we did, but more importantly, for planning for the future. Some of the barriers I've mentioned are lack of smartphones, lack of hardware within many of our clinics to do video consultations, challenges with Wi-Fi, which occur in many parts of our very large country, limited literacy with technology, especially for older people, and 90% or more of consultations are being carried out via the telephone. But we did have lots of innovations and many clinics setting up their systems to be able to do video calls when appropriate with their patients. This is the service breakdown in the first year in 2020 compared to 2019. 2019, the telehealth items hardly show because there were so few of them funded under the MBS prior to the pandemic. And then in blue, you can see the telephone consultations. In orange, you can see the video consultations. And you can see that we rapidly moved from the beginning of the year into the second quarter, April to June, with more than half of our consultations between Australians and their chosen healthcare providers occurring via telehealth. So again, a very good example of digital inclusion. Secondly, in our themes was looking at making sure we could set up services so people with symptoms of COVID-19 could get rapidly tested. And one of the innovations which we introduced in Australia was COVID-19 point of care testing. And this was particularly in remote Aboriginal community controlled health organisations and other primary care settings in remote parts of Australia. Now, normally if you're living in one of these areas and you need to have a pathology test, the test is taken and it's sent off, and it may be 10 days or 2 weeks later that it's got to a laboratory, it's been processed, and a result comes back to the healthcare provider who ordered the test to share with their patient. This is clearly unacceptable during a pandemic. We need rapid diagnosis and rapid management. And in Australia, we rolled this out, point of care testing for COVID-19 tests into Australia. And it was the world's first use of COVID-19 point of care testing happened in remote Australia, happened very early in the pandemic. And results were available with the initial tests that we had available to us in under an hour. This is before rapid antigen tests were introduced. I know they seem to have been with us for a long time, but they came later in the pandemic. And this gave us real-time data to communities, to the people providing care to their patients and to our policymakers, and was a very important innovation. It also blew out of the water the myth that you can't have high-quality pathology testing occurring in remote clinics where you don't have a pathologist on staff. We were able to set this up and run these tests very effectively, and now we're seeing more point of care testing being made available to people in remote areas. Again, a really good example of digital inclusion coming out of COVID-19. Thirdly, we wanted to have regular healthcare services available to the whole population, including when people were in lockdown or people were required to be in their own homes. And so we saw the rollout of e-prescriptions, again, happening very quickly early in the pandemic to allow people to do their telehealth consultation with their chosen healthcare provider. And then if a prescription was needed, for that prescription to be an electronic prescription and for the patient to be able to either send that to their pharmacy of choice or for it to be sent directly by the healthcare provider, the pharmacy then being able to dispense the medicines and deliver them to people in their own homes without people having to break out of isolation. The electronic records, we've had electronic records for a long time, but the electronic records came into their own as well, with healthcare providers who themselves were required to be in isolation after a diagnosis of COVID-19, still being able to consult by accessing electronic records remotely. And My Health Record, I think it came of age during COVID-19, finally with a purpose that was accessible and available to everybody through the linkage with the Australian Immunisation Register and with the Medicare app, to show that people had had their vaccinations for COVID-19 and to show where they're up to in their vaccination schedule. I imagine many of you would have on your smartphones now your COVID-19 vaccine history and can see when you're due for your next booster. Finally, protecting and supporting our healthcare workforce. I've mentioned how important this was for equity and equitable access for healthcare workers wherever they are working. We had personal and protective equipment, PPE, distributed through our national medical stockpile, delivered through our network of primary health networks across Australia. The delivery and request data was being monitored again using digital technology, and this allowed us to keep up to date with the ordering of huge volumes of personal protective equipment into our national medical stockpile. The government had to take responsibility for PPE at a national level, because the supplies that we had in hospitals and clinics across the country were rapidly depleted as a consequence of the pandemic. And it showed our one of the challenges of relying on essential equipment to come from overseas. Who knew that most surgical masks were made in Wuhan province in China before the pandemic, and we had to look at other sites for getting our PPE. We also set up our 150 respiratory clinics across the country where people could go and get assessed if they had symptoms of COVID-19. Again, real-time data for the first time in Australia being drawn from sites all over the country to tell us about who was attending, what were the diagnoses, what were the test results. And this, again, has helped us to show how important national primary care data collection is and to have that shared. This is a chart which is probably not unfamiliar to many of you, just showing what happened with the first two waves of COVID-19 in Australia. The first wave occurring in March and April of 2020, and then that terrible second wave, which occurred predominantly in Victoria. The data coming through every day from the states and territories about diagnoses of COVID-19. You might think that we have had all this all set up and ready before the pandemic, but it was not available in such a way, and the states and territories each had their own way of collecting and gathering data. We had to build systems so that we could have that data at a national level available to us in the National Incident Room based in Canberra. So lots of other innovations using digital technology with surveillance systems and with sharing what was happening with COVID-19, not only across Australia, but with colleagues from around the world. You will have seen the reports from each country around the world through the WHO telling us what was happening with outbreaks of COVID-19 and with the emergence of new variants. We're using geospatial analysis. The National Incident Room is a secure room in the Department of Health in Canberra, which is opened when we have a national emergency. It was already operating by the time COVID-19 appeared because we had the bushfires occurring on the east coast of Australia, and we'd had the White Island volcano disaster off the coast of New Zealand with a number of Australian tourists being killed and seriously injured as a consequence of that emergency. So the incident room was already functioning, and we were able to look and see what was happening up on the screens with the spread of COVID-19 across the country by local health districts, and then what was happening with the vaccines when the vaccines became available and started to roll out as well. We had daily reports on what was happening with vaccine rollout. And seeing how many doses were being administered and how we were going in each of the states and territories. Of course, many of our vaccines, in fact, most of our vaccines were delivered through general practices and a large number of the rest through community pharmacies, a small number of our vaccines delivered through mass vaccination centres set up by the states and territories. We also had a number of new tools which were developed, and some of these you will have used yourselves to find out, were you eligible yet for a vaccine? And did you meet the criteria to register your interest if you were currently ineligible, so you could be told when you were eligible and the vaccines would be available to you, to find the vaccine clinic closest to you, over 5,000 sites initially where you could get COVID-19 vaccines, and then integrating with the clinicians to provide information and allow each of our sites to order and make sure that they had vaccine supply available on hand for when patients presented. And we used digital mechanisms to share information about COVID-19. I think we saw a huge amount of misinformation during the COVID-19 pandemic, but the go-to place, we hoped, for the Australian public was health.gov.au, the Australian Government Department of Health website, for people to find the latest up-to-date information about vaccines, about COVID-19, and about what people could do to protect themselves. The final story I'm going to share, my apologies to those who were in my talk yesterday, because you heard this story yesterday. Those of you who didn't, including those online. One of my roles as Deputy Chief Medical Officer was a couple of times a week. I had the privilege of standing up in front of the Canberra Press Gallery and the nation's media to deliver the daily update on what was happening with COVID-19. Had to squeeze it in between Premier Gladys Berejiklian and Kerry Chant and Premier Dan Andrews and Brett Sutton with the outbreak updates in New South Wales and Victoria. But I deliver the update and then take questions from the Canberra Press Gallery. We had someone from the department who would film the press conference and would then release the video onto Facebook and other sites on social media, so it could be shared around the country and around the world, as well as going out live on national television. One day I did my press conference, and a couple of hours later the media team rang me up, and they were all excited because my press conference had had over 2 million views in just a couple of hours. It had gone viral right around the world, which was incredibly exciting. So I thought, wow, I must have said something really important. I better go and have a look at the press conference. So I went and had a look, and what I discovered was that I had been filmed upside down, and it had been sent right around the world and was going viral with the Doctor Down Under delivering the COVID-19 update for Australia. So you can become a meme without even expecting it during these things. What happens next? Well, what happens next, really importantly, is we currently have a national inquiry into the Commonwealth's response to COVID-19. And that, I hope, is going to produce a number of recommendations on what we need to be doing to be better prepared for next time, and the areas that COVID-19 shone a spotlight on. And particularly for this audience, digital inclusion is incredibly important, and we need to have that inquiry know where things worked well and where things did not work well for different priority populations within Australia. So I urge you, if you haven't already, to think about your experience with COVID-19, and if you wish, make a submission to that inquiry. I expect that even if the initial submissions have closed, they will have papers for people to respond to. It's very important that everybody thinks deeply about what happened during the pandemic and how we can make things better for everybody when we next face, and of course we will face, another national emergency or global emergency of this sort. Thank you very much. Thank you, Ian.
Thank you very much, Professor Kidd, with that incredible demonstration of the impact of digital technologies and their impact on delivering healthcare. It's a message we should all take away. So it's now my pleasure to introduce to you Professor Deborah Lupton, who's joining us online. Deborah is the Sharp Professor in the Faculty of Arts, Design and Architecture here at UNSW. She's affiliated with the Centre for Social Research in Health and the Social Policy Research Centre. She leads both the Vitalities Lab and the UNSW node of the Australian Research Council Centre of Excellence for Automated Decision Making and Society. Deborah is the recipient of 2 honorary doctorates for her contributions to her field, and she will be presenting today what do people find useful about digital health technologies and what are their barriers to use. And these are findings from her social research with diverse groups in Australia. Professor Lupton.
Okay, I assume everyone can hear me. So thank you for inviting me to speak today. And yes, I'm going to talk about Australia's use of digital technologies for health, benefits, barriers, and risks. Now, I'm a sociologist as well as someone trained in communication and media studies. And 2 of my special kind of areas of research are health sociology and digital sociology. So I bring the 2 together to engage in what I call critical digital health studies. And because I'm a sociologist, I'm really interested in the determinants of health. We now have a term that we use in the literature called the digital determinants of health. And that it's related to the social determinants of health. But what we're interested in looking at is social inequalities and social justice issues and how some social groups and people living in certain areas of the world or even areas of Australia are sort of shut out from access to digital technologies that they might be able to use to improve their health. And so the term critical digital health studies, as I see it, is about challenging techno-utopianism and solutionism. We see a lot of internet companies and digital tech developers really spruiking their goods and sort of overdoing it, often with the hype. In terms of saying, well, this is going to be a solution for every health problem or most health problems. And yes, sometimes digital health technologies are really fantastic and do really help people. But on the other side of things, I'm really interested in looking at identifying the social, cultural, political, and ethical implications of digital health technologies. I've written a few books that cover these issues of critical digital health studies. So this is Digital Health, Critical and Cross-Disciplinary Perspectives as part of a Critical Approaches to Health series with Routledge. I've written a book on the quantified self, subtitled The Sociology of Self-Tracking, that looked at the whole phenomenon of sort of quantifying the self, monitoring, measuring the self, and why it became, I guess, a big deal about a decade ago now. There was a lot of noise about the quantified self movement, and a lot of people started taking up self-tracking using digital technologies. And as a sociologist, I was interested in exploring the social dimensions of that phenomenon. And then in this book, Data Cells, which came out after the quantified self, I was interested in looking at how people made use of their personal health data. So I drew on a lot of my research projects that I'd conducted thus far to use a sociological analysis of, again, I guess, the benefits for people, but also the barriers and the risks involved. So I do cover that, a lot of that empirical research in this book. But what I'm going to talk about now really is all the different projects I've conducted over the last decade on digital health. And then I'm going to just do a bit of a synthesis and an overview of the findings sort of coming out from across these quite varied studies. So as you can see from this list, and they're sort of in a chronological order. So I started off at the top there, looking at women's use of digital media for pregnancy and parenting. So things like apps and online discussion forums, pregnancy tracking apps, infant care apps. And so I've sort of got a combination of projects that look at quite specific uses of digital health technologies, but also projects that take more of an overview. So the second project I did looked at self-tracking cyclists. I guess I've also put the methods next to each of them. I'm not going to go into any detail about the methods, but I guess you can see from that list of methods for each project that I like to explore and experiment with methods. I like to do creative methods and innovative methods, often based on design, sort of research coming out of human-computer interaction studies, as well as sort of creative sociological methods, just to really get at how people experience digital technologies for health, and how those technologies are incorporated into their everyday lives. I'm also really interested in looking at how people imagine the futures of digital health. Basically, if they feel that some technologies and devices haven't yet been invented that work well for their own purposes. I also do quite a lot of research asking people, okay, if you could invent a new digital health device, what would it be? What would it look like? How would it work for you as part of your everyday life for your own purposes? So the second project looked at self-tracking cyclists. We actually used a GoPro camera, a little action camera attached to people's helmets, and took a video of their ride, and we could therefore had a video that we could look at and talk to people about later in terms of how they looked at their data, whether it was on a bike computer or on their wrist as a smart watch or a phone with an app on it, and if they looked at their data during their ride, what other things they were focusing on their ride, and those sorts of things. So that's just an example of video ethnographic approaches to looking at people's use of digital health technologies. I did a big project on people who self-track for any purpose. That included health self-tracking as well as things like productivity and financial self-tracking. Then I focused in on women, and I was really interested in how women across a range of age groups and I guess health statuses use digital health across the whole array of digital health technologies available to them. And that one part that I was interested in, we know that women are often the sort of information seekers on behalf of family members. And so what I did find, for example, in this study was just simply Googling for health symptoms, doing a bit of self-diagnosis, even self-triage, I would argue. A lot of women across age groups do that to try and work out whether their own or their family member needs, if they have symptoms that actually require medical intervention, medical consultation, for example, but also right up to and including self-tracking devices, such as Fitbits and so on. And I guess what might surprise some people is that middle-aged women are very avid users of fitness tracking apps and devices like Fitbit, and actually enjoy a bit of friendly competition with friends or family members. So that's an interesting finding from that project. Digital health stakeholders is where I got together a whole group of people working in digital health, whether it was the Australian Digital Health Agency members or people of the Pharmacy Guild, or healthcare professionals and midwives, as well as lay people. Got them together in one big room, and we did some design methods, mapping the landscape of digital health and talking about what new devices they would like to see introduced into the digital health landscape. I've done a project on young people's use of digital health, so people aged 18 to 26, and what they find super important for their purposes. Just one interesting finding there was YouTube was really valuable for them. They loved looking at peer-made videos on YouTube to support their mental and other health issues. I did a project looking at teachers' use of digital health and digital tech and health and PE classes. And that was interesting too, because one important finding there was that teachers aren't really thinking of, even though they're using tech like heart rate monitors with their students, they're not really thinking about the privacy issues of collecting those personal health data from their students. I've done some creative sort of writing project around people's use of digital health information from all sort of sources online and offline. I've done a project with a colleague in the UK who works on an online sexual health diagnosis service, and talking to people who use that service about what they find beneficial and helpful. I've done a project on people's use of digital technologies at home during COVID. That includes not just for health, but actually it's related to health and mental health, because it looks at how people manage to transition to working from home or studying from home or supervising children studying at home, but also how they communicated with family and friends using just simple things like messaging apps, for example, and of course Zoom. I was a commissioner on the Lancet Commission on Governing Health Futures, which was a policy report published in the Lancet a few years ago, looking at policy around regulation around future health technologies, particularly in relation to young people. I've looked at people's use of information sources during COVID, what they found most useful when the pandemic erupted, and they were really left in a space where they were just really wondering what the risk was, what they could do about it, how the government was reacting and responding. I've done a project looking at psychologists' experience of offering telepsychology during COVID, interviews with psychologists about that. I've done a project on health information ecologies, looking at how people use lots of different sources of health information across digital and non-digital sources. I'm currently working on a project on people with long COVID. There are more and more people with long COVID as people are still getting infected and reinfected. The pandemic is definitely not over. And we're getting at least 2 waves a year here in Australia. So the more and more people getting long COVID because they're just getting infected and reinfected. So this project interviews people with long COVID about how they use self-tracking devices to track their symptoms. And finally, I'm doing a project at the moment looking at the use of digital technologies as autism supports. So across, and this is just some examples of some of the creative approaches we take, such as at the top left there, that was the digital stakeholders workshop where we got people mapping that landscape of digital health. At the bottom there, people, and to the big picture on the right, people making collages about what works for them in terms of digital health, and again how they would like to imagine the future of digital health that would work best for them. And this is some of the digital health ecologies maps, hand-drawn maps or handmade maps that people made, including digital and non-digital sources of information and support. That's another one that someone made with an online tool. And as you can see just from that one, you've got Google, you've got social media, going down a rabbit hole, Googling. You've got the smartphone, but also this person talked about his wife and how that supports his health and well-being, and even providing some information about health, but also the leisure pursuits that really help him feel well, talking with others, food and cooking, music and celebration, for example. And this is just some grabs from a film, a short documentary film we're currently making about autism support. So on the right, we have one of the participants who loves her robot dog, Ivo. That is a digital, it's not digital health technology, but it is a digital technology used for health and well-being. And I like to take that really expansive approach by acknowledging there's lots of technologies that aren't necessarily designed for health, but are used for health and well-being purposes. And then on the left there, another participant who's talking about their headphones and how a simple device such as that really helps them get through the day as an autistic person. So just to go over the benefits, bringing together the findings from all these different studies together. So the benefits of digital health technologies that emerge from these studies: finding information instantly, better knowledge and awareness of people's body and health, just using online sources and self-tracking, data generating devices and apps, feeling more in control of their health. That came out a lot with, say, people with a chronic health condition who are using at-home care devices, improving their fitness, health and well-being. That's something that a lot of people talk about. They really enjoy the use of apps, self-tracking apps and wearable devices to make them feel as if they can see from their data that their fitness, health and well-being are improving. Better access to healthcare services. So as Michael mentioned, telehealth, especially once the COVID pandemic erupted, and a lot, it was very difficult for people to access healthcare services in person. It was fabulous how they were able to access telehealth and telepsychology services. Fewer doctor visits, as I mentioned. People often self-triage and they decide whether in fact, the symptoms they're experiencing are minor, or whether they do in fact need to seek out expert help. And I would say here too that it's not just about Dr. Google doing all the doctoring. People do really still value medical expertise. It's not as if they're Googling and then just using online sources. They're Googling to decide whether they need the medical help that they really still value and trust. People feel motivated and reminded about things like monitoring their health and fitness and well-being using digital devices. They enjoy sharing information. So, for example, on fitness tracking or athletic or cycling tracking platforms like Strava, people really do get motivated by comparing their data with other people and giving other people support and congratulations on doing well with their personal bests and so on. People really enjoy social connections to others and peer support. As I mentioned, young people really enjoy YouTube and these days TikTok also as a way of communicating with other young people about the health issues that they may be dealing with or they may need further information on. So those peer networks are super, super important really across the age groups, but particularly for young people. Feeling less alone, that comes out with a lot of marginalised groups, LGBTQI people living in rural communities, for example, where they're able to go online and actually, you know, at home, they may feel very reticent about coming out and being who they are in their community, their small community, but being able to do so online is super important for their mental health and well-being. Also, people with rare conditions or chronic health conditions or otherwise sort of misdiagnosed or just not acknowledged conditions, peer support online is really, really helpful and for information sharing as well. And anonymity. So some people do, and I guess that gets back to what I've just said, some people do appreciate the fact that they can go online and feel as if they're connected, but not necessarily needing to share their identity. But risks and barriers. People did talk about information overload. As we know, there's heaps of information from very reputable sources, if not quite a few less reputable sources online. But you know, once you start Googling, for some people it can get a bit much. Sort of, they know what websites to go to and who to trust. You know, government sources, major charities, for example, like the Heart Foundation. They absolutely know that they're the ones to trust. But you know, once they get going down that rabbit hole, sometimes it's difficult to know what they should do with the information, and often they will then go and seek medical advice so that the doctor can actually help them make sense of it. Digital inequalities, which I talked about in terms of digital determinants of health. As Michael mentioned, we still, even in Australia, have pockets and large pockets of the country, particularly remote and rural communities, that have very poor digital access in terms of Wi-Fi and other phone data and other infrastructures available to them. Even some areas close to Sydney are kind of blackout spots in terms of getting good signals and Wi-Fi services. There's poor design of devices and software. So talking to people, say, who have disabilities that make it difficult to sort of handle their smartphone and type in information into their app, if that's what's required of a tracking app, that just doesn't work for them. When I spoke to women who were just about to give birth to a baby, so they were 8 months pregnant or so, and they said that whereas once their Fitbit worked really well for them, it wasn't designed for people who are heavily pregnant and are a bit slower walking up steps or walking up hills, and also for people who are in the throes of early parenthood, and obviously they know for themselves that they're not sleeping well. They don't need a device to tell them that. So they did talk, those types of people did talk about how they would love apps to sort of just give them encouragement and not sort of nag them about not sleeping well or not moving their bodies as much as they once did. Poor quality of data. So it depends on the app and the device, but some don't actually generate very good data that actually help people do anything to use those data. Personal data privacy and security are really important issues. We've had so many personal data leaks and hacks in Australia, ranging from Medicare details to, of course, the Optus hack and many other hacks in between. So that's something that should be on top of mind for everyone who encourages people to use or who are thinking themselves about using digital self-tracking devices. Loss of face-to-face support and expertise. So we don't get to a situation where we're relying too much on digital health technologies, because people do really appreciate having that face-to-face support and expertise when they know that they need it. The invisible labour, that gets back to people with a chronic health condition or a disability, sometimes finding it very difficult just to keep up the sort of work that they need to do to enter in their data or making sure that they're monitoring their condition regularly. Over-reliance on self-help and self-responsibility. There can be a bit of a tendency in digital health circles to sort of say it's all about you as an individual to manage your own health. But of course, as we know, as we've talked about in terms of digital determinants of health and social determinants of health, there are many members of the population who simply don't have the digital literacy, don't have the digital access, don't have the money to buy fancy devices and software or even data plans. So that means that finally there can be a loss of focus on social determinants of health and social justice issues that I think we just always need to be aware of. And finally, where to from here? So this is just things that I'm working on now. So I'm interested in digital One Health. So how can we bring, and we don't have time to talk about this today, but how can we bring human and planetary health together in interesting ways and use digital technologies not just to track the health of humans, but also to track the health of ecosystems, because as we know, humans are always part of ecosystems. And so it's in our own best interest to make sure that planetary health is being monitored and that we limit digital waste and huge burdens on water use and on energy use that using a lot of digital health technologies can create. Of course, there's the whole generative AI for health that's burst onto the scene that I'm having a look at the moment. And just continuing on with creative and arts-based approaches and exhibitions for research, translation and community engagement, because I think it's really important just to get these issues out there into the general community to help them think about the future of digital health and think about and reflect on their own uses and to think about privacy issues and planetary health issues and all those sorts of main issues that I've discussed today. Thank you very much.
Thank you very much, Deborah, for the insightful talk. I'm told by the team we have to wrap up by 2, so I'm just going to jump straight in to a question. Michael, I really like the principles you shared and how inclusion was really baked into them. I think question for both of you, but Michael first. How do we help innovators or people doing research in digital health make sure this is top of mind and bake them into what they're doing?
Thanks, Ian. It's really important, isn't it? It's important that when we're developing new technology, we're actually thinking about the uses and the users. And so engaging particularly with future consumers is very important. And particularly engaging with those who may be disadvantaged in some ways. And Deborah showed us wonderful lists of people where disadvantage may occur, and being upfront. For the Commonwealth, it's absolutely essential, of course, because the Commonwealth is providing health funding for health services for the entire nation, and so everybody needs to be included. But for commercial entities, often that's not part of the thinking. But if you want to make sure your product is going to be used universally, it needs to be. So working with the target groups.
Deborah, did you have a comment on that question?
Well, yeah, I guess just doing, I'm not to bang my own drum, but just doing the kind of research I am doing, doesn't have to be me, it can be everyone else who's doing this really great research. I mentioned human-computer interaction studies, people who actually do come out of computing and information technology. They do wonderful research, and it does get back again to doing research with the end user, not just making assumptions about what people might want, which happens a lot in the major digital technology development space, but doing a lot of end user research to make sure you are actually designing and developing products that people want, that they can use easily, that are inclusive and accessible. Super, super important.
Thank you. We had a question from Kathy online. Can we see that?
Oh, hi. Gosh, that's very dark, isn't it? I just wanted to say thank you for both your talks, Professor Kidd and Professor Lupton. And my talk is specifically for Professor Kidd around telehealth. I'm a PhD candidate at UCID researching how knowledge is produced around contested chronic illnesses in Australia, looking at myalgic encephalomyelitis, chronic fatigue syndrome and long COVID. And I'm interviewing health professionals and those living with ME/CFS and long COVID. And just with relation, Professor Kidd, to telehealth, moving forward in an inclusive way, and keeping those involved that are disadvantaged, as you mentioned, such as those with ME/CFS or long COVID. What are your thoughts about, so it's come through in my research that a lot of people with these illnesses, part of the disability is their inability to leave their home due to severe energy deficiency and crashes post minimal amounts of effort. So to have access to equitable healthcare, they need to access telehealth. They can't always get to doctor's appointments physically, and that would include even initial consults with specialists, and they're already struggling financially, as many of them aren't able to work. And I'm just curious, moving forward, what is the state of play with telehealth in that area for assisting the many that are now disabled from long COVID following the pandemic?
Thanks.
Sorry if that was long-winded.
No, that's great. Thanks, Kathy, and thank you for highlighting those areas. You know, telehealth should be transformative for the healthcare being provided to many people with disability, many people who are disadvantaged in different ways, whether that's through challenges with mobility, whether it's through being located remotely from where regular health services are available, so people in rural and remote areas. There is a big focus with the Commonwealth review and reform of primary care on multidisciplinary care. So care from multiple different healthcare providers, which can be particularly important for people with the sort of conditions that you've been mentioning with ME and people with long COVID, but also people with many chronic conditions where there's benefits from having consultations with doctors, nurses, allied health professionals and others. We are seeing in the wake of telehealth having its revolution over the last 4 years, the development of a lot more virtual services. I was in Dubbo in rural New South Wales last week and saw their amazing virtual services offering virtual access to rural generalists, to emergency medicine specialists, to a range of allied health professionals, and also to community pharmacists to assist people with medication management challenges, and all this being done virtually using telehealth consultations. So I hope we see more of this developed and the continuing rollout of telehealth. I hope we're going to see more video because there are additional advantages when video is being used. But hopefully this continues as very much part of our national reforms as well as reforms at a local level. Thanks.
Thank you, Michael. My sincere apologies to everyone who does have a question. We do have to wrap up, but that just leaves me to thank our guests, Professor Kidd and Professor Lupton. If you give them a round of applause for taking the time and spending that time with us. Really insightful. And that just leaves me to hand over to the University of Sydney team for closing remarks. But at the same time, I invite everyone here to head to the back for some refreshments and post the session. Thank you, everyone.